Hello, and welcome to a pre-recorded webinar that will introduce you to the Millon Adolescent Clinical Inventory 2. It's been more than 25 years since the first Millon Adolescent Clinical Inventory was released, and I'm very happy to share this revision with you. Significant changes have been made to the inventory, and I'm going to review them with you. I believe that MACI users will be very pleased with the new instrument and the information it provides, especially when you read through the 10 to 12 page interpretive reports that can be generated. I studied with Dr. Millon at the University of Miami many years ago, and my learning experiences and later collaborations with him have been the true high points of my professional life. The overarching goal of this revision was to develop an inventory that would be a worthy contributor to his legacy. During a series of meetings several years ago, Dr. Millon and I discussed the merits of all the changes that have been implemented, as well as some that were not. Dr. Millon envisioned the evolution of the clinical assessment field given the challenges that adolescents face in this day and age in comparison to when the MACI was developed. Therefore, he wanted to develop an inventory that could meet the current needs of today's clinicians and evaluators. I believe he would be proud of what the teams from Pearson and Dicandrian have created. So what is the MACI-II? The MACI-II is a 160-item self-report inventory that has been designed to assess personality characteristics, according to Millon's theory, as well as clinical syndromes in adolescents who are undergoing psychological assessment and/or treatment. These evaluations can be psychological, neuropsychological, or psychoeducational in nature. While the MACI-II would ideally be administered at the beginning of treatment, it can serve as an outcome measure as well. The MACI-II normative sample consisted of more than 1,100 adolescents in clinical settings. Therefore, it should not be administered to those who are not undergoing an evaluation or participating in treatment. Here are some quick facts about the MACI-II. Innumerable people had various roles in the project, and it could not have been completed without them, and especially the invaluable contributions of co-authors Drs. Seth Grossman and Carrie Millon, as well as Pearson research directors Drs. Catherine Presnell and John Camp. The MACI-II remains at 160 items with 48 new items. It is rated at a 4th grade reading level, and it's available in English and Spanish, including audio recordings. It usually takes 20 to 25 minutes for an adolescent to complete the inventory. This slide highlights many of the updates that we'll talk about. It illustrates that the revision of the MACI-II is more than window dressing. Many substantive changes were proposed and have been implemented. For example, the MACI-II has 2 combined gender normative groups: younger adolescents who are 13 to 15 years old, and older adolescents who are 16 to 18 years old. There are 3 types of interpretive reports: male, female, and gender neutral. Also, we addressed concerns regarding item overlap on the MACI by changing the scoring system, and we have added several new scales, including 3 clinical syndrome scales and 3 Grossman-Facet scales. This slide presents the family of Millon inventories that would be appropriate for use with pre-adolescents, who are 9 to 12-year-olds, adolescents, 13 to 18-year-olds, and adults, 18 or older, in clinical settings, and the Millon Behavioral Medicine Diagnostic, which is normed on patients in medical settings. The MACI-II has evolved from its predecessors, the Millon Adolescent Inventory, which was first developed in 1974. The MAI was the precursor to the Millon Adolescent Personality Inventory, the MAPI, which was first published in 1982, and the Millon Adolescent Clinical Inventory, first published in 1993. The MACI was updated in 2006 to include the Grossman-Facet scales, and the evolution continues in the MACI-II in a number of significant ways. So what's new among the scales? The MACI-II has 3 new validity scales that we will review a little later. They are named Invalidity, Inconsistency, and Response Negativity, and they have replaced the Reliability Scale and the Modifying Indices from the MACI. The MACI-II has 11 personality pattern scales. The inventory does not offer personality disorder diagnoses, and there are 2 reasons for this. First, the DSM-5 discourages such diagnoses with adolescents. And second, in keeping with Dr. Millon's conceptualization of personality patterns falling along a continuum from normal to disorder, the MACI-II measures personality types, traits, and features. Now, we'll stay on this slide for a bit, so just stay with me. Dr. Millon introduced his personality theory in his 1969 text, Modern Psychopathology. At that time, the theory was formulated as a biosocial model of personality development, with a strong emphasis on positive and negative reinforcement. In brief, at the core are 3 polarities. The first polarity is the pleasure-pain polarity, which focuses on the nature or type of reinforcement. The pleasure component focuses on the ability to seek happiness, to connect with others, pursue achievements, and enjoy successes, while the pain component focuses on the avoidance of danger, threats, sadness, anxiety, rejection, disapproval, among other things. The second polarity is the active-passive polarity, which represents the modes by which an individual may elicit positive reinforcement or avoid punishment. Active personality types are characterized by their alertness, persistence, and proactive approach to eliciting or securing what they want or desire in regard to pleasures and rewards, or evading the distress of punishment or anxiety. Passive personality types, on the other hand, tend to exhibit an acquiescence to their environment and wait for others to take care of them, allow others to assume leadership roles, and expect good things will come their way with little to no effort on their part. Finally, the third polarity, the self-other polarity, corresponds to the source of the reinforcement. Some personality types have learned that feelings associated with pleasure or the avoidance of pain are provided almost exclusively by others, while other types have found that self-reliance and autonomy are necessary to ward off vulnerability and derive a sense of self-satisfaction. Over the ensuing years, Dr. Millon advanced his theory to an evolutionary model, and the same 3 polarities, while conceptually modified, are combined and configured to identify, define, and explain the personality patterns that are measured with each of the Millon inventories. Therefore, the most important defining feature of all Millon inventories is that his theory serves as the foundation and guide to assessing and understanding these constructs. Additionally, one's personality provides the context within which all other concerns or syndromes are seen. I'll be covering Millon's personality theory, its polarities and domains, in more depth in a future webinar. For now, it's back to this slide regarding the MACI-II, which has 4 express concern scales, while the MACI had 8. We'll review those changes and the rationale behind the decisions to drop scales a little later. And finally, there are now 9 clinical syndrome scales. The increase from 7 such scales on the MACI reflects challenges that many adolescents face today and that clinicians and evaluators need a way to assess. This slide adds some material regarding the Grossman-Facet scales. Each of the 11 personality pattern scales has 3 Grossman-Facet scales. These scales reflect the most salient traits that are associated with each personality type. The facets correspond to key domains that are typically assessed. For example, an adolescent's behavior, interpersonal conduct, self-image, or moods. Therefore, the facet scales help maximize the clinical utility of the personality pattern scales and help refine the overall personality assessment. This slide outlines the functional and structural domains within Millon's theory. Millon's theory posits that there are 8 clinical domains through which each personality pattern is expressed. Each of the personality pattern scales has 3 corresponding facet scales that represent aspects of the primary personality patterns. The facet scales provide information on the most prominent domains underlying each personality pattern. For each personality pattern scale, the 3 domains measured by the Grossman-Facet scales are shown in bold in this table. For example, the most salient characteristics of the egotistic personality pattern are their exploitive interpersonal conduct, which is evident in taking advantage of others or taking others for granted, their expansive cognitive style, which is noted in their tendency to bask in perceived successes or to take liberties with objective realities and truths, and their admirable self-image, apparent in their high levels of self-confidence and self-worth. The Grossman-Facet scales were updated for the MACI-II based on the identification of the 3 domains for each pattern that fit the theory best and on a rational examination of the item composition of each scale. Those 3 new facet scales, by the way, are for the dramatizing scale, which is the fickle moods facet scale, the forceful scale, which is hostile moods, and the borderline tendency scale, interpersonally paradoxical. Potentially, the greatest benefit that the facet scales provide is the ability to deduce theoretically based, clinically sound case conceptualizations that can translate into treatment approaches and targets. A number of scale changes have happened at the personality patterns section. 11 of the 24 clinical scales assess stable and enduring personality patterns. In Millon's theory, the personality patterns are the central constructs because they represent our overall capacity to perceive and to relate with our psychosocial world. The MACI-II personality pattern scales correspond to many of the personality disorders recognized by the DSM-5. For example, introversive, schizoid, inhibited, avoidant, submissive, dependent, dramatizing, histrionic, egotistic, narcissistic, unruly, antisocial, forceful, aggressive, sadistic, conforming, compulsive, discontented, negativistic, aggrieved, self-defeating, masochistic. However, acknowledging that these constructs fall along a continuum and that an adolescent's personality traits may change or fluctuate in frequency and intensity during this developmental stage, the MACI-II personality pattern scale names are less severe, and elevations on the scales do not indicate that personality disorders are present. The personality pattern scales on the MACI-II reflect advances and refinements in the test's underlying personality theory. New items were written for each scale, and for the first time, the Borderline Tendency Scale has prototypal items designed to assess the corresponding construct specifically. For example, items for this scale tap into whether someone engages in self-injury, has challenges regarding or regulating their moods, and experiences intense shifts in their feelings for or toward others. On the MACI, the Borderline Tendency Scale was made up of prototypal items from other scales. The doleful scale from the MACI was removed for the MACI-II because adolescents often co-elevated on this scale and the Depressive Affect Clinical Syndrome Scale. This made it sometimes difficult to differentiate between a long-term personality-based construct and a common, more responsive to treatment, depressive clinical condition. In addition, the name of the scale 8A was changed from oppositional on the MACI to discontented on the MACI-II. The name of scale B was changed from self-demeaning on the MACI to aggrieved on the MACI-II. And again, scales 8A and 8B correspond to the negativistic and self-defeating masochistic personality disorders, respectively. Let's talk about changes to the Express Concerns section. The MACI-II includes 4 scales that assess express concerns, feelings and attitudes about issues that tend to concern troubled adolescents. The scales are identity diffusion, self-evaluation, peer insecurity, and family discord. The first 2 scales may be seen as self-oriented, identity, and confidence, while the latter 2 scales are other-oriented, regarding peers and family, how well one fits in, or how supportive others may be. Now, 4 MACI Express Concern scales have been dropped. They include body disapproval, sexual discomfort, social insensitivity, and childhood abuse. The first 2 scales were dropped because they did not elevate often, and other psychological issues have emerged as more pressing and relevant to assess in clinical practice today. The social insensitivity scale was dropped because when it was elevated, it did not represent an actual concern for the adolescent, and the lack of empathy and compassion toward others is still captured by the unruly and forceful scales. Some items from the childhood abuse scale were retained, and they have been supplemented by new items to create the post-traumatic stress scale. Let's look at some changes for the clinical syndrome section. The MACI-II includes 9 scales that assess acute and transient clinical syndromes. Clinical syndromes such as anxious feelings and depressive affect are often the initial focus of treatment. An adolescent may be so overwhelmed or distressed that they ask for help, or notable changes in their behaviors, thoughts, and or moods may prompt others to suggest that they go for professional help. Also, please note the substance abuse proneness scale. Adolescents were willing to endorse alcohol and drug use items on the MACI, and I suspect this will hold true with the MACI-II. And for those working with more behavior-disordered adolescents, you will commonly see elevations on the delinquent predisposition scale, along with the unruly and forceful personality patterns scales. Let's look more specifically at some of the changes that have been made in this section. The name for Scale AA was changed from eating dysfunctions on the MACI to binge eating patterns on the MACI-II. Items assessing anorexia symptoms have been removed. Therefore, the scale is now focused on binge and overeating and bulimic symptoms, which may not be as apparent as anorexia symptoms. The impulsive propensity scale on the MACI was dropped from the MACI-II. Impulsive tendencies are captured, however, by several other scales on the MACI-II, including the Disruptive Mood Dysregulation Scale. And here are the 3 new scales that have been added to the MACI-II. These were added to identify important conditions that reflect current clinical presentations among adolescents. They are the Disruptive Mood Dysregulation, Post-Traumatic Stress, and Reality Distortion Scales. Many of you out there may be saying that a fairly high percentage of your clinical work with adolescents these days has some trauma component to it. Therefore, in developing the Post-Traumatic Stress Scale, we set out to place a heavier emphasis on trauma-related symptoms than its predecessor, the Childhood Abuse Scale. As MACI users are well aware, you could not assess an adolescent for psychotic symptoms with the MACI because none of the items address the issue. That has changed, and the Reality Distortion Scale serves that purpose. Test takers will be responding to items that assess if they are questioning their grip on reality, having fears that they are losing touch with reality, or even hearing voices. Positive endorsements will alert us to these important concerns. And finally, long-standing and persistent problems with anger, frustration tolerance, and impulse control are assessed with the Disruptive Mood Dysregulation Scale. Elevations on this scale would indicate that an adolescent is acknowledging having anger discontrol problems and that these lapses have had a negative impact on their family and peer relationships. Okay, so this slide tells us what the MACI-II looks like in terms of scales and items. As a result of changing the item weighting system from 0 to 3 to 0 to 2, many scales are considerably shorter than before. The number of total item loadings across the test dropped dramatically from 888 to 290. Yet correlations between the common MACI-II and MACI scales remain strong, with 15 correlations being 0.80 and higher. For example, the introversive scale has been reduced from 44 items to 13 items, and the correlation between the 2 versions of the scale is 0.91. Similarly, the depressive affect scale has been reduced from 33 items to 15 items, and the correlation is 0.93. The lowest correlations were found on the 4 MACI scales that had more prototypal item changes, and those were the submissive, dramatizing, egotistic, and anxious feeling scales. So why is the MACI-II unique? The MACI-II was created to assess an adolescent clinical population. Therefore, it should not be administered to normals or adolescents who are not undergoing an evaluation or receiving treatment. Since it is clinically focused, it is not particularly strengths-based either. However, in each interpretive report, the opening paragraph in the personality patterns section will provide a less severe description of the overall picture, which might be helpful to clinicians who are trying to explain the results to an adolescent or their parent or guardian. Start with something more palatable and recognizable in the adolescent's repertoire. And also, if you view things along a continuum, someone is not functioning at the tails 100% of the time. There will be moments or instances in which almost any behavior or attitude may be adaptive. I don't think I can overemphasize the importance of having Dr. Millon's personality theory provide guidance and direction in understanding a person, who they are, what factors have influenced who they are, what are their vulnerabilities, what tendencies might perpetuate their pattern, and so on. His theory helps us make sense of what we see clinically, and therefore, it is more than, is this adolescent anxious or depressed? The real question is, who is this adolescent who is anxious or depressed? With this in mind, different interpretive paragraphs are generated for all the expressed concerns and clinical syndrome scales, depending on the adolescent's underlying personality patterns profile. And additionally, all the treatment guides have been rewritten to enhance the therapeutic focus of the interpretive reports. What are some other key features regarding the MACI-II? The normative sample consists of more than 1,100 subjects who are being seen or evaluated in clinical settings. That includes 570-plus females and 560-plus males. The two age groups allow us to look at differences between those in early adolescence versus late adolescence. For example, a difference between the two age groups was found in the prevalence rates for the reality distortion scale. These rates were computed according to clinician ratings, and a higher percentage was found in the older group. That may speak to the often reported emergence of serious psychopathology in the later adolescent years. Another feature that we believe places the MACI-II ahead of the curve is the ability to generate gender-neutral reports. We hope to convey a message of inclusivity to those test takers who do not identify within the two binary choices, so that they may opt to leave the gender prompt blank or make another choice. For clinicians, the report will have all male and female pronouns removed. This option required many changes in sentence structure, but all were well worth it. And there are still other key features. In order to complete the update, 48 new items have been introduced. The majority of these items were needed for the development of the borderline tendency, disruptive mood dysregulation, post-traumatic stress, and reality distortion scales. 6 new items have been retained that do not load on a scale. Instead, they are included in the noteworthy responses section. All of us are aware of the need to identify those who may be at risk to engage in violent behavior. For this purpose, 3 vengefully prone items are included, and they seek to identify ideation, intent, and potentially planning one's revenge. There are 3 bipolar spectrum items also. We were not able to create a bipolar spectrum scale, but elected to retain items that tap symptoms including excessive energy with a decreased need for sleep, extreme mood swings from highs to lows and vice versa, and impulsive and reckless actions while in a manic state. A MACI-II report does not provide definitive diagnoses. However, it does offer clinicians DSM-5 diagnostic conditions to consider, especially when base rate scores on the clinical syndrome scales are elevated. Many of the diagnostic considerations offered have incorporated the underlying personality pattern profiles. For example, if an adolescent elevated on the anxious feelings scale, one diagnostic consideration would be generalized anxiety disorder. If the highest personality pattern scale is a submissive scale, we might consider separation anxiety disorder also. On the other hand, if the highest personality pattern scale is the inhibited scale, we might consider social anxiety disorder. Here is the first of 2 slides that provide information on the normative sample. You can see important demographic shifts in this slide. More adolescents from diverse backgrounds are involved in psychological treatment or the evaluation process. Therefore, each group, other than white, has increased in its representation within our normative sample. Here is the second slide. You can see from it that we are able to gather data from many settings. However, there was a dramatic shift from before. For the MACI-II, the vast majority of cases were gathered from outpatient settings, either clinics or private practices. We speculate that there may be two primary reasons for this. The first is that hospital stays are much shorter than they were when the MACI was developed. Therefore, it is less likely that psychological testing is being conducted in that setting than before. Also, hospitalizations are generally for acute stabilization now, not really for intensive treatment. It's possible that residential and hospital settings are likely to have more rigorous IRB processes to go through than the others also. For those clinicians working with juvenile defenders, take note that 10% of the MACI-II normative sample was gathered from juvenile justice and corrections settings. Let's take a quick look at some of the reliability numbers that we have. Internal consistency values, measured through Cronbach alpha, are acceptable to good. This slide provides the mean alpha across the 24 clinical scales for the two age groups. These represent slight decreases in comparison to the MACI. However, Cronbach alpha is partially a function of scale length, and the MACI-II scales, as has been noted, are significantly shorter than their MACI counterparts. The test-retest correlations are quite strong, with the median falling at 0.90. In order to establish external validity of the MACI-II, subjects completed either the Minnesota Multiphasic Personality Inventory Adolescent Version Restructured Form, the Behavior Assessment Scale for Children, 3rd edition, Self-Reported Personality, Adolescent Version, and the Beck Youth Inventories, 2nd edition. Among the scales that might be of particular interest to you, I'll review the correlations that were found between these instruments and their respective anxiety and depression scales. The MACI-II Anxious Feeling Scale has a 0.82 correlation with the BYI-II Anxiety Scale, a 0.87 correlation with the BASC-3 Anxiety Scale, and a 0.64 correlation with the MMPI-A-RF Anxiety Scale, as well as a 0.78 correlation with the Negative Emotionality Neuroticism Revised Scale from the MMPI-A-RF. For the MACI-II Depressive Affect Scale, correlations with the depression and demoralization scales from these other instruments were all 0.90. How about MACI-II Scores? Like its predecessors, the MACI-II uses actuarial base rate data, which is collected through clinician ratings. The MACI-II produces scores that reflect the underlying prevalence rate of a pattern or a syndrome in a clinical population. Base rate scores are a type of standardized score that reflects the different prevalence rates of the characteristics a test measures. The key numbers to look for in a MACI-II profile are base rate scores at or above 85, which represents the prominence of a condition, and base rate scores between 75 and 84, which represents the presence of a condition. With base rate scores, we do not assume that all personality patterns or clinical syndromes occur with the same frequency. For example, that anxiety occurs with the same frequency as psychosis. In addition to base rate scores, percentile scores were developed for each scale, and they are actually the primary reporting statistic for the Grossman-Facet scales. Well, let's take a look at the MACI-II interpretive steps. As usual, we would start with basic demographic information. What do we know about this adolescent? Their age, background, family system, school, presenting problems, etc. Next, regarding step 2, we have to check the validity of the MACI-II profile. For this, we check the invalidity scale and the two new validity scales named inconsistency and response negativity. We changed the items for the invalidity scale so that they are now very direct inquiries regarding whether the adolescent is answering truthfully or not. We expect the score to be 0 on this scale. The inconsistency scale consists of 31 semantically similar item-response pairs. It was developed to identify discrepant responses to items that are usually answered similarly. Each inconsistent response pair contributes 1 raw score point to the scale score. We expect scores to be in the 2 to 3 range most of the time on the invalidity scale. On the inconsistency scale. The invalidity and inconsistency scales rely on raw score cutoff points, and the combined invalidity-inconsistency index is recommended for the detection of random responding. Profiles will be classified as valid, questionable, or invalid, which will be noted at the top of the profile page. Finally, the response negativity scale consists of 42 items. Essentially, 2/3 of these are negative in content and 1/3 positive in content. And it was constructed so that high scores represent an undifferentiated pattern of negative responses across the items. In other words, high scores reflect a high number of true responses to items with negative content, as well as a high number of false responses to items with positive content. Raw score values are converted into percentile ranks, and clinicians will be interpreting these percentile ranks. For example, what would it mean for an adolescent to score at the 90th percentile rank on this scale? Could it be that the adolescent has an unusually large number and broad range of problems, like you might see with complex trauma or high levels of family dysfunction? Or does it represent an over-reporting or exaggeration of problems for some reason? We have handed the decision-making back to the clinician rather than having a computer program make score adjustments without knowing the context of the case. MACI-II profiles, therefore, do not have computer-generated adjustments behind the scenes. After reviewing the validity and response negativity scales, we check the borderline tendency scale because it represents a severity gauge among the personality pattern scales. What is different on the MACI-II is that this scale now has 7 prototype items of its own and 10 subsidiary items. Of note, it has high alpha values for both age groups, and among the personality pattern scales, the borderline tendency scale has the highest correlation with the suicidal tendency scale from the clinical syndrome section. The personality patterns section will often have 2 to 3 scale elevations, and these scales will be interpreted together. Next, we would look at the Grossman-Facet scales for those 2 to 3 personality pattern scales in order to further refine our interpretations. However, we would still look at all 33 facet scales for further information. The personality patterns profile creates the context within which the expressed concerns and clinical syndrome scales will be interpreted. We'll review the noteworthy responses next, especially the vengefully prone and bipolar spectrum items because they do not load on any clinical scales. At the same time, we want to check the items that assess suicidal ideation and self-injury and other areas of concern. Scale elevations on the 24 clinical scales will translate into diagnostic considerations. Finally, fully revised treatment guides address treatment targets, approaches, strategies, and modalities that could prove efficacious. We have a case example today, and it is of a 17-year-old female of Asian descent. She lives with her parents who were born overseas and immigrated to the United States before she was born. She reported that her parents have not assimilated to American culture and she and her parents communicate in their native language at home. She experiences her parents as controlling and reported they don't understand her life here, for example, the social challenges she faces. She further reported that her parents set high expectations for her and that she is, quote, never good enough. Frequent comparisons to her high-achieving older sister and her peers have left her feeling down about herself, despite her own legitimate talents. She was seeking treatment because of feeling depressed, as well as her struggles coping with the breakup of her first relationship, which turned out to be an unhealthy one, marked by taking advantage of her, wanting to be loved. So when you administer the MACI-II and you have it scored, here's the full profile page for the interpretive and profile reports. All 24 clinical scales are presented in graph form, according to base rate scores in 3 sections, with the validity scales and the response negativity scale reported above them. You will see in looking toward the top that this is a valid profile because the invalidity score is 0 and the inconsistency score is 2, which falls well below the cutoff raw score of 7, which would indicate a profile is of questionable validity, or 8 or more, which would indicate a profile is invalid. Response negativity is viewed according to percentile rank, so 55 places her right in the middle. There is no indication, therefore, that she is over-reported or under-reported. In regard to severity, her base rate score of 53 on the borderline tendency scale actually places her below the median of 60. Also, there are no indications of lapses in reality testing, giving her base rate score on the reality distortion scale. Remember, the base rate anchor points are 85, which represents prominence, 75, which represents presence, and 60, which is the median point. Scanning through the profile, we see elevations on the aggrieved, conforming, and submissive personality pattern scales, the self-devaluation and family discord express concern scales, and the depressive affect and binge eating patterns clinical syndrome scales. So let's break these down. I'll point out that the 3 highest elevations on her profile in this section, the personality patterns section, were obtained on 3 passive polarity-oriented personality pattern scales: aggrieved, conforming, and submissive. Now, starting with some adaptive features, this profile suggests that she wants to be seen as a giving and compassionate person, one who is selfless and concerned about others. She has strong desires for closeness and affection, and will act in accommodating and benevolent ways in order to secure them. By seeking approval for others, putting their needs before her own, she hopes to elicit acceptance and validation, as well as to avoid rejection or abandonment or a sense of disappointment. That all sounds pretty good. However, her elevated base rate scores, especially on the aggrieved scale, which is at 100, further suggests that she tends to see herself in a negative light, to court undeserved blame and criticism, while allowing others to take advantage of her. Her repeated experiences have contributed to a deepening ambivalence over whether to continue to acquiesce to and appease others, or to assume a more assertive and self-reliant stand. This conflict will linger because at this time she does not have sufficient positive self-worth to walk away from unhealthy relationships. Instead, she holds on to what limited and intermittent rewards others offer. She has internalized negative comments and perceptions from others and sees herself as an ineffective and undeserving person. It is unlikely that she will express anger toward others or act out, because that would threaten whatever close connections and sources of approval she has. Instead, she is more likely to internalize her frustrations and disappointments, leading her to feel misunderstood, trapped, and helpless. Let's look at the Grossman-Facet scales on this slide because they may further refine our impressions. The interpretive and profile reports will present in graph form the 3 facet scales for the 3 highest personality pattern scales in sequential order, as long as the home personality pattern scale has a base rate score of 60 and above. In our case, the aggrieved personality pattern scale was highest, followed by the conforming and submissive scales. The 3 highest facet scales among these 9 will be interpreted in the report according to their percentile ranks, as long as that percentile rank is 75 or above. For us, the expressively disciplined facet scale from the conforming scale would be interpreted first, followed by the undeserving self-image and cognitively diffident facet scales from the aggrieved scale. It would be appropriate to look at all 30 scales to see if others surpass the 75th percentile rank. Here, see the interpersonally docile facet scale would be reviewed, as well as the alienated self-image facet scale from the inhibited scale. The expressively disciplined facet scale informs us that she prefers routines and predictability, and she tends to construct her world in terms of rules and regulations. This approach may serve a function of doing right by others in order to elicit approval and to avoid criticism. While it is probable that she periodically succeeds in this pursuit, her elevated undeserving self-image suggests that she often focuses on and magnifies her perceived weaknesses and feels that she deserves to be shamed and demeaned. It is probable that she has learned not to take chances because doing so could create vulnerability and a risk of failure. Therefore, she avoids taking actions that could potentially enhance her self-esteem. And finally, her lack of self-confidence leads her to withhold her thoughts and opinions, and in contrast, to mold them to others. This slide represents the Express Concerns and Clinical Syndrome scales, and 2 key elevations are found in the Express Concerns section. A central issue, given her base rate score of 115 on the self-evaluation scale, which is the highest that the base rate scores can be. This elevation represents a pervasive sense of self-dissatisfaction. A poor self-image is sustained by amplifying perceived flaws or shortcomings and downplaying positive attributes or real achievement. Also, the elevation on the Family Discord scale suggests that she sees her family as a persistent source of tension and conflict rather than support. Given what we know now, there is little surprise that the Depressive Affect Scale is elevated. Although she is dependent on others for nurturance, she harbors deep ambivalence and resentment in response to what she perceives to be others' unreliability and untrustworthiness. Her fear of venting anger toward them is connected to fears that rejection would be forthcoming. Her resolution to this conflict is to turn anger inward. Burdened with low self-esteem, believing she is not worthy of good things, and worried about losing her closest connections, it is highly likely that feelings of despair and hopelessness will periodically emerge and potentially activate thoughts of self-harm or suicide. A quick look at the noteworthy response section revealed that she had endorsed an item related to contemplating self-injury. Her MACI-II brought something else to light. At initial contact, she had not shared that she engaged in disordered eating behaviors. Her elevation on the binge eating pattern scale revealed that she engaged in overeating and binge eating episodes. Upon inquiry, she talked about how her parents would call her fat and question her eating habits. She has become self-conscious about her body, appearance, and eating. She noticed a tendency to eat more while distressed, potentially setting in motion a vicious circle in which she struggles with negative emotions pre and post episode. Use of the word considerations in regard to diagnostic considerations was carefully thought out. The MACI-II offers DSM-5 diagnostic categories for the clinician or evaluator to consider, and they will ultimately decide what the most accurate diagnoses would be. Today's case generated the following diagnostic considerations: aggrieved, self-defeating personality type with conforming, compulsive, and submissive dependent traits, as well as persistent depressive disorder and binge eating disorder. Finally, with all of this information gained through the administration of the MACI-II, each interpretive report will include a fully updated treatment guide. The question is, what do we do now? In this case, clinical interventions would target her depressive condition, low self-esteem, negative self-worth, and disordered eating pattern, in addition to building her repertoire of coping strategies and improving her assertiveness skills. Cognitive, interpersonal, and behavioral approaches, as well as individual and family treatment modalities, would be considered. The negative messages she has internalized need to be explored and reworked to a fuller and more realistic self-portrait, including embracing her aptitudes and strengths. Her underlying wishes for connection and acceptance would be validated, and her pursuit of them shifted toward healthier paths in which relationships are based on mutual respect and trust. The ultimate goals would be to address the issues identified in her profile, to have gained insight into how certain personality traits could perpetuate her troubles if they are not addressed, and to impact the trajectory of her life toward greater self-satisfaction and overall well-being. Please note the various ways to learn more about the MACI-II and how to access customer support, whether by phone or online. Thank you for listening. I hope you found this introduction to the MACI-II to be informative and that you are intrigued by what it has to offer.